everyone. Thank you for being here. Thank you to the organizers, Bessie and David, for inviting me to speak today. Can everyone hear me? Yeah? So I feel like this is a great, Heather, thank you for beginning us today. And the aesthetic practice, that arts-based practice really does come from within our bodies. And so I really want to talk about that embodied practice that we live and how we live it through stories we know, we tell, we re-story. All good? Oh, thanks. Yeah, the mask. Oh, yeah. Thank you. Yeah, okay. So I'm going to skip through. I have no conflicts of interest. For learning objectives, I just like this to be a dialogue, a critical reflection on our individual and collective stories, the value and danger of these stories, and our work is not linear. It comes in a spiral-like way, so I hope we will circle around with stories. So as we begin, I'd like to ask, what grounds you? I have to think about that myself right now. But what grounds you in your practice? And nurses that I spoke with in palliative care around their own mindfulness practices, and they took that up in different ways, really approached that in a lot with great diversity. One nurse said, "When you walk in the woods, the peace, the air feels different. When I breathe it in, it feels cleansing. It calms and grounds me. The feel of the air, more than anything else, it's intangible, but it's very real." So please take good care of yourselves as we have this conversation. I invite you to get up, move around, and just to hold yourself and one another compassionately. So as Bessie said, this book was recently published, and that quote, and anytime you see italics on any of these slides, they are quotes and passages from 9 nurses that I spoke with around how they work to be embody and work through the complexity and relationships central in nursing practice. And it is both something we can see, we can witness it in an image, someone sitting on the bed with this beautiful eye contact, making connection, but it also is very invisible. I'd like to also acknowledge, as I begin, my co-supervisors who stayed with me for a very long time through this process. This is my dissertation work. Dr. Christine McPherson from the University of Ottawa, and Dr. Anne Bruce from the University of Victoria, as well as David, who really generously wrote a foreword for this book. One of my favorite pages is in the front matters with a list of palliative care nursing stories. And basically they're passages from the stories to help title them so people can find them. There's 30 of them in the text. I'd like to just read some of those passages, and they are passages that relate to working with patients, people who are dying, families, and the team and their colleagues. And I'm going to read it slowly. You're welcome to close your eyes or watch. I'll put the titles up and just have a moment of silence after and invite you to consider what arises for you. Am I dying? You feel your heart. I paused and took a breath. It would have touched your soul. I have never been afraid of that room. She's dying uncomfortably. I was caught up in the moment. One child, a big tumor on her neck. We paused and looked out onto the ocean. A really awful death. How come every time I come in your office, I cry? Could someone else go in there right now? I got an ache in the pit of my stomach. Those were the longest minutes. You can be more creative. You do what works. The nurses, the 9 nurses that shared with me their practice, they came from traditional palliative care settings, hospice, home and community palliative care units. And we know palliative care is, as an approach and way of being, is hopefully living in a lot of other spaces, and particularly through this last number of years. It was very humbling to complete this work, to really kind of come to the end as the pandemic was beginning. So I had tried to dig into, how do we be with suffering? How do we be with strong emotion? And then I was like, oh, how do I be with suffering? How do I be with strong emotion? Because it went, in a significant way into those spaces. So as we've already been discussing, we have a great commitment as palliative care nurses to this relational way, to authentic engagement, to compassion for others and hopefully for ourselves. And that there's this inner sense that guides our actions, or it can if we're listening. But it's also a really difficult practice. Here are some quotes. There can be a heaviness. It was just one of those ones that stuck. I think we all have little files. The weight of it is piling up. One nurse said, "You wonder if you have spots in your body that sort of hold those tensions or emotions or some of the things that you're witnessing." Another, and it made me think of the image that the private images that Heather spoke to. In nursing, you wish you had a button to just unsee things. So there are things that you just see that people would never have to see. Wendy Austin and colleagues, in their text about Canadian healthcare providers' experiences of compassion fatigue, and I'd like to just say I think that word's being problematized and critiqued, but nevertheless they have a story in that text about the impacts of caring on the body of a particular nurse, Veronica, who shared feeling absolutely nothing as a 2-year-old girl undergoing treatment for a serious medical condition uttered the most screaming kind of scream. Looking back, Veronica names that she had become hardened. I think it was quite courageous of her to share that. And over time, no longer recognized herself in her caring practices. Like the authors, Wendy and colleagues who share Veronica's plight, this image is compelling, a body hardening. This is their quotation, a body hardening, its skin becoming callous, stiff, unyielding, and within a hardened heart. And going back to a nurse that I spoke with, who was trying to make sense of how to be with the work that she was doing, she said, "You still want to have a tender heart." I was very fortunate to be able to speak here in 2018 when I was trying to make sense of what I was hearing alongside other palliative care nurses. And when I spoke, I was speaking about, I was in that conference talking about returning to the heart of practice, rediscovering the heart of nursing. And that's a phrase from a scholar, Draper, in our nursing work. And had referenced a few stories. Well, when nursing were telling me stories, they put their hands on their heart or their chest. And the second time that happened, in particularly in relation to that story of the young child with a tumor on their neck, I said, "Is there something here you're gesturing to?" And she reflected that she needed to learn how to breathe into her chest. And after that presentation, one of the people in the audience came up and thanked me, and also said they were going to change their practice. And what they had been doing, she said she felt like there were people sitting on her chest and her heart, and she had been for some time rubbing really hard trying to get them to leave, and that she was going to open her hand and invite them to stay. I offered a bit of a reflection back, and I'm going to read something within the text. In between the chapters, I have just one-page reflections on my own process. So after 3 years as a nurse in hospice and palliative care, I had the opportunity to move back to a small island on the west coast of Canada and rest and contemplate and finish undergrad. And, even though I said I'd be done school forever, I applied for graduate school at the same time. But I was trying to make sense of the work I had done. So I moved back to Haida Gwaii, a remote island in northern British Columbia. I was born in this place, and most of my memories from there are as a young girl. Arriving, all the contemplative practices adopted to engage as the hospice nurse seem to slip away. Instead, a knowing of self and body is found through deep rest and many walking meditations. Sacred land and time hold and care for me. And in the dark of the night, with eyes closed, I watch as people I once cared for, through their dying, gather around, laughing and crying and tensing in terror of the unknown. Dream after dream, people no longer living, yet still so present, making their significant impressions on me clearer. In the experience, I ponder how to return to work caring for people through dying while nurturing clarity. A dialogue where evocative stories take the lead become my aim, and it invites my body and body in general, because I think it's the invisible work, some of our invisible work, invite the body to come along into an exploration of our deeply relational work in palliative care nursing. So I shared a very brief discussion of that, and I used to think that when I was having those dreams, those people I cared for were leaving my body. They're still with me. Years later, some of those images come back, but there's a little bit more space around them, and maybe they're carried in a different way. How do I get back? So there's great value to stories, and I think we've been talking about that through the last few days. It can support sense-making, integration of experience, relational awareness, support connection within ourselves and with others who we are in that storytelling and listening process. Stories beget stories, and I'm very curious of what has arisen for you so far in this conversation. And stories can guide actions, like fairy tales when you tell them to a child. They can shape what we morally believe is right and move us forward. Tara Brach is a contemplative psychologist, and she shares that emotions, a combination of the physical sensations and the stories we tell ourselves, continue to cause suffering until we experience them where they live in our body. If we bring a steady attention to the immediate physical experience of an emotion, past sensations and stories linked to it can be that have been locked can become de-repressed. I also think of Dr. Murtagh yesterday in the keynote, who said there is value in freeing the untold stories. It's not easy always to move within these stories, to share them. As one nurse said, I admit sometimes it's too hard. Another nurse said that depending on the day and who you're with, there may be too many stories in the room. And so where and how do we share them? I also, it was interesting to me to hear a reflection on, we know that debrief can be helpful, but as one nurse described, sometimes it's so vulnerable that maybe one-on-one or in a small group would be better, but they had lost their physical office space. Like, where do we even go to have these conversations? And I learned also from a nurse practitioner, Maurice Bouvette. Their team used this stop sign analogy. I'm a green light today. I'm yellow. Please, I'm here for you, but let's go with caution. And today, it's also okay to say not today for me. So just thinking about that for ourselves, and do we allow that? I'd like to tell a story from Heather. And Heather, I'm gonna offer, this is some writing from the text as well. And this is in conversation during an interview. Heather speaks through a poignant story. I take out a box of Kleenex from my bag and place it on the table. The experience she is sharing is about caring for a young woman, April, a wife and mother of 2 small children who is dying after a long and protracted serious illness. For symptom management, April was transferred to the hospital, and Heather describes the impact of watching April's husband and 2 children who step out of the room and down the long hallway to go home for the evening. The husband is holding the young one's hands. Heather finds herself touched as she connects with the woman on many different levels. She says to me, "Yeah, maybe that," as she pulls tissue from the box. Meanwhile, in the pause, I linger on Heather's last words. It feels wrong to hold myself back just because I might hurt, or it might hurt. With emotional undertones that were thick in the room and between us, I ask if it would be okay to continue the inquiry. Could we stay here a little more? Sure, she says, and I don't sense her hesitation. Building on what Heather has already shared, I reflect, I think it is significant, that intention, allowing yourself to hurt, to feel hurt. And I don't know if you want to stay on this particular situation, but I'm wondering if you'll speak a little bit more about what it means to move within those things that come up. Heather continues into her memories of caring for this young woman. And it was just remarkable that she could carry on and go further. What she finds hard is not doing more. One evening, after her nursing shift in the community is over, she decides to go and sit with the woman who is, by this time, continuing to get symptom management in the hospital. And the woman mostly sleeps. However, in a moment, she wakes up and looks directly at Heather, breaking the silence, and asks, Heather, am I a bad mom? Heather recounts what unfolds next between them. Why do you think you're a bad mom? And she said, because I can't do this with my kids right now. Am I bad for not wanting them to be with me? And I said to her, you are dealing with cancer that is all over your body. You are dealing with your arm not working, your legs not working. You're dealing with nausea, with a tube that's going into your nose that's trying to empty your stomach for you. You have little ones that like to pull at tape and pull on tubes. They don't understand your stomach's sore. And I said to her, if you can't do the mom thing right now, that's okay. That does not make you a bad mom. That makes you human. I said, it's okay. I think you're a wonderful mom. You've got great kids. And after that conversation, April went back to sleep. And as Heather describes, the fact that I was there, maybe she couldn't ask that to somebody else. But she was able to ask me. I was sitting there because I needed to be there. But when she asked me, I thought, well, maybe she needs me a little bit. Maybe that I was just the right person to ask that question to. As Heather draws to the end of the story, she reflects back the idea of feeling hurt and her choice to share this experience. I'm just human, and that's part of being human. It's all right to go to those places. In this story, Heather also draws parallels with her own life. The woman is around the same age as her daughter. The woman's children are around the same age as her grandchildren. The way Heather works with experience such as these is to bring it back again to self-awareness. I knew I was getting too involved, she said. It was touching too much. So those are times I need to be very aware of myself. I tell this story now in part to just reflect upon the courage and commitment that nurses have working to uphold dignity and humanity, our own and others, through the significant moments of serious illness and dying. I'd also like to talk about not only the stories that we have, but how we might work with them. And although I'm not talking anything about methods from this research, I'm greatly influenced by a sociologist, Arthur Frank, who wrote a book called Letting Stories Breathe. How do we allow them to move and take shape? And later on, he wrote another work that said maybe I should have, instead of titling the book Letting Stories Breathe, suggest that we need to keep our stories strange. So I'll use a story to talk about this a bit further. We talked yesterday in one of our present room dialogues, one of the presentations, I think actually it was a layer that came through multiple times, was the importance of preparing family for what's coming next. And that's a very significant storyline that runs through many of our stories. And then there was a nurse, I'll call her Erica, and she was sharing about a wife who came in to visit her husband, and her husband was imminently dying. He was no longer speaking. It was clear that he was in a transition time. And the nurse came in, so this is again the nurse, Erica's words. And his wife came in and was all bubbly and happy. "How are you doing?" she says to her husband. "Let's sit you up." And then she turns to Erica and says, I want to feed him. And I asked her after she sat there, do you have time to talk together? Would you be open to that? And the wife said, sure, I'd love to talk to you. So we went and found a quiet place, and I sat down and I said to her, I don't know if you realize how close your husband is to passing. I would not expect to see him when I come into work tomorrow. And she was like, oh, really? So it was a time to have a discussion, and I said to her, would you like me to explain what I'm seeing so that you know, or would you rather not know? And she said, no, I don't want to know. I said, okay, well, can you tell me about your husband? And so Erica describes how the wife took her on this amazing journey. She learned about the husband and wife's life together, coming to a new country, creating a community of love and care around them. And Erica said, I went home and my cup was full. In this story, Erica supports an opening up of possibility and choice for the wife to act in ways that she directs. Tina, to use the word from another nurse in the study that I did, seemed to value not having an agenda, instead of focusing on the wife's actions to try and feed her husband who is imminently dying, and to try and get her to stop for the risk it poses, or providing education so that she'll be prepared for his dying. She offers the wife other opportunities, and they go on that amazing journey. So there's a few other tensions and storylines, and I'm sure there's probably more, and as your own stories came up now, I wonder if you might identify some here. But there was another story from a nurse who was caring for someone in home who looked to be in a trajectory towards end of life, and the son didn't believe it to be true. He had watched his father go through episodes of congestive heart failure, be treated and supported, and actually that's what happened when they did that, and the son, the father had more time together with the son. And so the nurse reflected later, again with great courage, that we had our own idea what was going on, and it wasn't right. Also, we have great commitment towards relief of suffering, and yet a nurse says you can get into the idea that everyone should be perfectly comfortable all the time, and a lot of people don't want to be. So being aware as a nurse, am I doing this for me, or am I doing it for them? And also, I think the nurses described ways in which they had great intentions towards the way they provide care, and if it didn't look that way in the end, there was this sense of failure or a sense of beating oneself up. And can we catch those narratives in our stories? Also, within these stories are some unsettling and ongoing problems towards the organizational environments that we work within. There are financial constraints, the technological advancements, focus on task-based care, that tension between providing individual and creative ways of care for people and families versus that standardized approaches that often creep up in organizations. The space that I spoke about that's not just emotional to speak about these stories, but actually even physical, and the structural inequalities. And I want to say that in this book, this is an invisible aspect of palliative care. There's no mention. And so I want to just quote Kelly Stadjahar, one of our teachers and leaders here in Canada, who wrote a paper, Provocations on Privilege in Palliative Care. People who live in poverty and who are otherwise made vulnerable by structural conditions in which they exist are almost invisible in modern-day hospice and palliative care. And I certainly reinforce that in the text that was published. I try to remember that you're becoming a permanent part of their story, said one nurse. That seems like a bit of a privilege in itself. Not that it puts pressure, but it makes you more aware and helps you get out of that automatic nurse task mode. That just flipped by there. Try to go back. So I think that there's great awareness for all of us that these stories go forward in various ways, that these experiences we have go forward as stories, and how can we support them to go forward in a good way. And also to think about how they shape us, so that I won't read the quote, but a number of nurses talked about what they've learned and what they take forward. And it is a great privilege, and there's great love, and there's, in the midst of all of this that I'm trying to call us to look on and to bring together to talk about the complexity, there's a lot of learning that we get the privilege to do through this work. I don't know, it's not working. Can you advance it for me? Oh, there we go. We're almost there. So this is a quote, and it's quite old now. It's from 1990 from a nursing scholar, that says about the relational stories of our work as caregivers. If these stories are woven together with care, nurses can collectively fashion a tapestry of rich and diverse experiences from which to pattern a nursing ethic. First, however, nurses need to tell their stories. In the story of Heather, that visit that she made and that very poignant exchange that she had happened after hours. Heather was off shift. And I appreciate that David, in his foreword for this book, adds to the dialogue in a way that I had not in the text, where he says, I think in concern for the idea that these kind of moments happen after a shift, one of the greatest nursing ethic challenges of our time is to rescue such crucial moments from being dismissed as extra to nursing practice, to instead recognize them as the core to the work that we do, work that requires skill, resources, and institutional support. So that is the end. Thank you so much for your attention, and I'm really looking forward to hearing what's arisen for you and any questions. And I also have some flyers if you'd like to read them. There's a discount on the flyer from the publishers, and I'll be in the exhibit hall after if later today you want to have a conversation. Thank you.
Don't go far, Lacie. Don't go far. I just wanted to thank you very much for this incredible presentation. As you were talking, I was thinking, as you said, so many stories, but so many common storylines. And I think for me, one of the beauty of story is that I can listen to one and see myself, or get meaning from it and fall back on memories that are very familiar. And I think that you offered these nurses an incredible gift in giving them the space to tell their stories, and you've gifted us with your experiences as well. So thank you. And I'm sure that there are questions in the group, and we have some time for questions.
Thank you so much, Lacie. I think we all probably feel invited to let those stories that are inside us bubble up and be part of things. And it connects to Heather's talk too. What I want to ask, the idea that the part of nursing that we're not supposed to, the rule breaking, is telling the stories. Mm-hmm. That is, I make my stories too. I write them down. These are things that have changed my life, and so I have tried to keep them. But I have a worry inside me that I'm not supposed to really tell them. So I think of these as telling my own story and talking about myself. And I've toyed around with, well, what would the foreword say? How do you actually talk about people and not get into trouble?
Oh man, maybe that's why it took 9 years to get to the end here. One of the reasons. Thank you so much for offering that and for sharing your process. And I think it's a really, really important conversation to have, because how do we maintain the sacredness of those experiences? Like, stories are one thing, but these are experiences that people have lived and breathed and moved through, and I don't think it's an easy answer. What comes to mind also is I was at a nursing conference, a philosophy conference, and there was someone I greatly respected that I had read their work, and I had talked about the need to share these stories, and they said, absolutely not. Like it's important to hold those, hold those in a sacred way. And I emailed after to say, can we talk more about this? And there was no further discussion, so there can be some pretty hard lines, but I think there might be ways to do that skillfully, maintaining the anonymity, the confidentiality, and I definitely was grateful to have, I gained confidence through supervisors, through external readers, to go forward with this, and I think we have to find some way, so thank you. Also, I want to, as you were sharing, I learned, it wasn't very interdisciplinary in the way I presented today, and I recognize that. I worked with a social worker at a hospice, and she taught me a practice of, with each person and family she cared for, she wrote down something she learned from them. And I just spoke with her after 12 years, and she showed me her books. It's remarkable, and she'd already been there for a very long time.
Wow, that's incredible. Thank you so much. So many things to think about. And the stories are so important, and the examples you gave are wonderful. But I wonder, when I hear the stories, if were the nurses documenting those things? And I hope they were. Like, not the whole story, but what the interventions and the skill that they were using in doing those things. And I brought this up yesterday, but I do document things like active listening and empathy and exploration of whatever concerns, fears, that kind of thing, but I don't see very many other people doing that. And I think we really need to do that, because that's part of what makes it invisible, is we do it all the time, but we don't tell anybody that we do it. And then we're not modeling for our younger colleagues as well, so.
Yeah, thank you. We didn't go there in the conversations. I do remember the only conversation I can remember from those, and it wasn't in the forefront of my mind maybe to ask as it arose. So thank you for bringing it to us again and again, because it's true. It is left invisible, and our work is not counted. And particularly for Heather, who worked after shift, I mean, I'm sure that didn't get in the chart. That she's having some trouble, like in terms of her identity as a mom, and maybe would it be the place to put it? As you're asking the question, I was teaching clinical consolidation practice experiences for nurses, and I was one of the students in my group cohort. She was an LPN going to an RN, and she shared this story of caring for one of her experiences of caring for a man who was really in serious condition, and it looked like a palliative approach would be very supportive. And he confided in her that he was very worried about his wife at home, who he was caregiving for. And I asked her, "Did you document that? Who did you share that with?" "Oh no, he told me that in private." So I think that we have a long way to go with that. And also, who reads and where do they read? So I think that was part of the conversation yesterday, is people skim over that, like narrative. I don't have time to read that narrative. So how do we share this?
I have a question and then a suggestion, and that is, I love that. And I think that a repository of stories that's informally added to by people, by nurses, could be really powerful. And I think it could help us get to the shared language, the common language that I was talking about earlier. I was on a webinar recently where a very skilled senior nurse was highlighting to nurses the fact that they constantly say things like, "I was just sitting with somebody," and her point was, every time you use the word "just," you undermine the value of what you're doing. And I think what I heard in your curation of stories is that you're helping nurses reframe elements of their experience that they might actually either be ashamed of or not even believe is important, and you're bringing it to life. So my ask of you is, does that repository already exist somewhere? And if it doesn't, could you set one up? Could you curate something? Because actually, I think this thing about confidentiality is a load of old tish-tosh. I think nurses have got great stories to tell. We don't have to give people's names, date of birth, addresses. Let's talk about the person that we met today, and let's share some of the richness and the pain, the inadequacy, the beauty of what we do through the stories. And I think you'd be a great curator. So
Thank you.
I would love to be, I'd love to see it, and I would love people to be able to contribute to something like that.
Thank you, Heather. My mind goes in many directions. First is that you'll see my Cape Breton University email is not up there. It's it's my personal one because I'm transitioning to another role. So we'll see how much time I have for curation in my new role. When I began this work, I looked for palliative and hospice care nursing books. And I think there are many of us telling stories and sharing our experiences. Formally and informally, whether it's authored or not. And I did have for a moment wanting to bring all those stories together. I think in addition to having the stories themselves, it's important to think about, as you mentioned, Heather, how we engage with storying. And I think what the privilege that I had was to have some time to think about that storying process through the work of Arthur Frank mainly, who's a sociologist. How are these stories living, breathing? How do we, I am more aware of the stories within me that aren't breathing, or that get stuck, or that I get caught up in, and how to shift and change. And so I think it's also about the framework for how we hold them or let them go into something else, into emergent creative practice. Great. Thank you.